Hi everyone! Today we are going to review a different approach to estimate annual budget in hospitals. But first of all, I have to say that the Mexican public healthcare is currently saturated, mainly because the population is getting older. The National Population Council estimates that in 2025, 52% of Mexican population will have 30 or more years old. Also, there is a growth in metabolic diseases in the last years, specifically in diabetes and hypertension. On the other hand, there is a little growth on healthcare GDP, being in 2019 just of 2.5%. Finally, healthcare sector has minimal private investment, 1,300 million pesos. That is less than 1% of total private investment in the period of 1924. In this context, the Mexican Institute of Social Security establishes a new policy a few years ago to put healthcare services free of charge to all citizens. Additionally, Inwork with Insabi requested to hospitals update their consumption data, specifically about medical supplies. It is important to say that COVID-19 pandemic stretched even more the system, creating a critical situation to hospitals not prepared to these factors. And one of them was the General Hospital Dr. Manuel G. González, which lacks of a team dedicated to constantly control and monitor expenses, and sometimes uses rudimentary elements to calculate costs, provoking a loss in time for medical teams and a reduction in accuracy in estimations. And for that reason, we proposed a new approach to mitigate the effects of recent circumstances. A software system based on four articulated elements. First, a costing method called Time-Driven Activity-Based Costing, TDABC, which allocates costs in processes depending on each one execution time. Secondly, an attempt to reduce uncertainty using physiologic tools. All of this automated with Microsoft Access and Excel, allowing physicians not wasting time on bureaucratic tasks. And finally, following a strict planning because of our limited resources. After a few conferences with the executive board, we agreed to implement our proposal in 9 medical departments, which were the most representative of hospital behavior. Also, these areas had the major available information needed for the method. Well, so the TDABC method was established by Robert Kaplan in 2004. It is important to say this method is an evolution of another one, also formulated by Kaplan, the activity-based costing, ABC. But the main difference is that TDABC allocates costs depending on the process execution time. This is possible because each department has a cost rate per unit of time. That means that depending on resource consumed and the available workforce of a department will have a specific cost to operate. We will see this in more detail after. But first, let's review the method main steps. First, we have to identify the processes executed in each area. It is important to every process is enough specific to sketch the area behavior. To doing that, we can use process maps, healthcare patient attention cycle, and care delivery value chain. These are tools that allow us to define the main interactions between the patients with the institution. For the case of the value chain, takes into account the path usually follows a patient. For example, in this slide, we can see the interactions for a severe knee osteoarthritis in each stage of the treatment, from the detection to the monitoring after procedures. Every hospital can determine its own patient path, but it is important to maintain consistency along departments. Next, we have to identify resource groups. These groups are for enclosing similar costs in one area. That means find a combination of resources that represents more accurately the consumption. Like the mapping, the institution has freedom to define which are their resource groups. For the Hea Gonzalez, we define 5, namely surgical, outpatient, diagnostic, ambulatory surgery, and therapeutic. Each one could have a specific resource combination. For example, ophthalmology department could have an ambulatory surgery, let's call division. And for work, they need 3 specialists, 2 machines, and 10 types of different supplies. This combination creates a segmentation that allows a more precise cost rate. We can see that in the next figure. The point is to collect resources expenses to obtain a total cost for department and division. In the figure, it is represented by this blue rectangle. As we can see, resources, the yellow ones, are allocated into auxiliary departments and divisions. The expenditures are determined for a period of time. To us, the better approach was in a 1-year period. But after calculating expenditures, we have to obtain the department's capacity. Another way of viewing that is thinking of the department's workforce. That means all human resources capable of doing work directly with patients. According to Kaplan, a way to do that is multiplying employees' working days times hours per day. In the case of the hospital, were 8 different contracts, each one with unique working hours. But these elements we have also multiplied with a factor that represents effective time of work. Because sometimes people got distracted using their phones, getting to eat, on whole chit chat. But having these 2 variables, it is possible to calculate the capacity cost rate. That means the cost every resource group will have to execute any process, and it is obtained dividing the cost and the available workforce. If we remember, these were calculated in the step 3 and 4. Once again, the step is expressed in the blue rectangle, but now is this one. And as we mentioned before, results from dividing department cost and available workforce. But by the way, we have to be consistent on defined time units, because we could make a mistake when we try to assemble the different data. Okay, so to make useful the cost rate, we need to compare it with the time for executing process. The hospital sadly does not have information about time, but physicians and department chiefs know the activities by experience, right? So we created an access form located in the figure on the right to collect data of every process. The form was deployed in the hospital internal network, and every area from their desk give to us the execution time data. As we can see, this form was for capture medical supplies consumption. Then the data was exported to Excel. Here, all operations were established to define total cost per activity. In the figure, we can see the activities, attach each one to resource groups with a specific cost rate. Then, here we can see the execution time in hours. So, with the the auxiliary departments and the unitary cost are multiplied to obtain a final process cost. Since supplies were captured from a different source, there's a field for that. Finally, we just sum the unitary cost and the supplies cost to obtain the total cost of each process. As we mentioned before, we use post-inference tools to reduce uncertainty, applied on execution times and supplies consumption. We have to do that because in medical practice there are no standards in patient treatment. I mean, there's not an only way to treat a patient, mostly because every person has unique conditions. So, the use of fossil logic grants a better estimation thanks to Jaeger index, which in this case was defined for three scenarios: optimistic, common, and critical one. And these concepts were easy to understand to physicians. But as I said, we used Microsoft Access and Excel to automate the method. Basically because the hospital already had the licenses and there was no extra budget to buy a more sophisticated software. In that line, we use access to store resources information. You know, human resources, assets, supplies, you name it. And it was useful to capture new information with formularies. Finally, Excel was used to actually execute the methodology, since all calculations and formulas were established there. And so, we're in the final part of the work. Let's see some results we achieved. In the figure, we observe final costs for each department analyzed in Mexican pesos. But getting beyond the numbers, I have to say the TDABC work well to administrative levels, because allows them to do a better decision making, since works as a set of indicators of department behavior. Also, there was a substantial resource saving to the hospital due to the easy deployment of the system. Moreover, it helps to reduce uncertainty and consequently request a more accurate annual budget to federal government and treat efficiently existing patients and the new ones for sure. Well, in conclusion, the system gives the hospital a way to have a constant information flow and have transparent data about expenses. In a way, it gives the opportunity to be more flexible in case some kind of crisis affects the institution and can react opportunely when needed. On the other hand, the physicians become aware of their activities and in consequence more responsible in resource use. Finally, this method can escalate without wasting unnecessary resources and will be an interesting option to implement into the entire second and third level network of hospitals. And as a note, I will tell you that in this April, the adapted TDABC method was implemented on the entire Hea Gonzalez Hospital to request their 2022 annual budget. Good news, I guess. But I think this is all. Yeah. So the references. So thank you, and I hope you enjoyed the presentation.